Good morning, dear students. In today's topic of discussion is uterine stimulants and uterine relaxants. Within probably 20 to 30 minutes, I will try to cover most of the important aspects of uterine stimulants and relaxants, which are important for your examination. So, the uterine stimulants are also known as oxytocin, and they can also be called abortifacients. These are the drugs which stimulate uterine contraction. And the examples are being placed over here: the posterior pituitary hormone, which is oxytocin, as well as the desaminoxytocin, the prostaglandins like PGE2, PGF2 alpha, 15 methyl PGF2 alpha, which is known as carboprost, misoprostol, which is a methyl ester of PGE1. So these are all potent uterine stimulants. Beside this, the previous ones which were used for other purpose also are the ergot derivatives, the ergot alkaloids which obtained from Claviceps purpura, ergometrine, methyl ergometrine. The miscellaneous ones are quinine and ethacridine. And the last one is a anti-progesterone one, which is called mifepristone. So all of them are basically called uterine stimulants. Now, in the next slide, we'll see the role of oxytocin as depicted in this picture. The hypothalamus is basically getting stimulated, and you see that from the posterior pituitary this oxytocin is produced, and from there it is released, and its effect is on the smooth muscle of uterus. So it's contracting smooth muscle of the uterus, and then the stimulus will come and stretch the cervix in late pregnancy. Whereas the same thing from the posterior pituitary with the oxytocin, which is coming and stimulating the myoepithelial cell, it contracts, and therefore there is milk ejection, and the stimulus of this milk ejection is sucking at the nipple. So from there the positive stimulus is going towards hypothalamus, and again from there the stimulation is coming towards secretion of or production of oxytocin from posterior pituitary. So this is the phenomenon which is happening physiologically in our body. Now, when oxytocin, which is basically a nonapeptide, is prescribed to a patient who is probably undergoing labor, then you will see that in small doses given via IV infusion, it exerts a physiological action on the pregnant uterus. So the baby actually pushes against cervix, causing it to stretch. So the stretching of the cervix is causing nerve impulses to be sent to brain. Then the brain stimulates posterior pituitary to release oxytocin. This oxytocin causes smooth muscle lining the uterus to contract. So this is the way the whole phenomenon is going on. But when you are giving the exogenous oxytocin or oxytocin from outside your body, you will see that in a small dose, the upper uterine segment, the upper one is basically going to be it's consisting of fundus, and the body is contracted. But the lower one, if you go back to the previous picture, the lower one, this upper one is going to be contracted, but the lower one, consisting of the cervical portion, is basically going to be dilated with oxytocin. So this is absolutely essential. Otherwise, this expulsion of the baby is going to be, a fetus from the uterine cavity is going to be restricted. So with low dose or small doses or optimum therapeutic doses of oxytocin, which is inducing labor, you will see a contraction at the upper uterine segment consisting of fundus and body, whereas in the lower uterine segment consisting at the cervical position, it is going to be dilated. This results in an expulsion of the fetus from the uterine cavity. The contractions also squeeze the maternal blood out of the placenta into the maternal inferior vena cava. The periods of relaxation which intervene between the two successive contractions allow refilling of placental blood vessels by the maternal arterial blood and thus prevent asphyxial injury to the fetus. And hence oxytocin can be used by slow IV infusion for inducing labor in term rather at term, in contrast to the other preparations which was being shown in the classification of uh, oxytocin, that is ergot alkaloids, ergot preparations, and it is always preferred over the ergot preparations. But ergot preparations were basically contraindicated in the prepartum condition. In high doses, this oxytocin increases the uterine tone, the contractions become more powerful, frequent, and asphyxial injury to the fetus may develop due to direct compression and ischemia caused by inadequate filling of the placental blood vessels. So, you must be very careful regarding the dose of oxytocin. In the mammary gland, it stimulates the myoepithelial cell. So it will stimulate the myoepithelial cell and modified smooth muscle which surrounds the alveolar ramification of the mammary gland and causes expulsion of milk from the alveolar lumen. And as I said, the sucking is basically acting as the stimulating impulse. So this is termed as milk ejection or milk let down. And the milk ejection reflex is, as I said, is initiated by stimulus of sucking, which results in the release of oxytocin. Now, in the cardiovascular system, small doses produces a vasodilator effect by direct relaxation of the vascular smooth muscle. Transient hypotension may happen, and it may lead to tachycardia, which is very commonly observed. This one is given orally. If you are giving it orally, it is inactivated by trypsin. So the aqueous solution on IM administration is absorbed rapidly. The TAP in non-pregnant lady is about 10 to 15 minutes. The removal from the circulation is mainly via kidney and the liver. The plasma from men and non-pregnant lady does not inactivate oxytocin, but the plasma and uterine tissue and the placenta in pregnant lady contain an enzyme termed oxytocinase, which inactivates oxytocin. The T-half of oxytocin in pregnant lady at term is approximately 3 minutes. And the common adverse drug reactions which we encounter is basically the water retention leading to water intoxication. It is characterized by nausea, vomiting, anorexia, weight gain, lethargy, and injudicious use may lead to premature birth, fetal death during labor, and too rapid a delivery or uterine rupture. So you must be very careful while prescribing these oxytocin. The injections are available as well as the nasal sprays are also available. It can be useful in the induction and augmentation of labor, hypotonic uterine dysfunction, to prevent postpartum hemorrhage, though the ergotamine or ergometrine is basically a better drug, and the miscellaneous uses like in intranasally, it can be given before breastfeeding to promote milk ejection. So the nasal spray is only for ejection of milk. The other drugs are prostaglandins, and as I mentioned, the different types of prostaglandins are used. PGF2 alpha and PGE2 in low doses stimulate both the tone and amplitude of the uterine contraction. 4 prostaglandins have been isolated from human amniotic fluid, and these are obtained during normal labor and during spontaneous abortion. Since PGF2 alpha has smooth muscle stimulating action, it is possible that it precipitates in the process of labor. PGF2 also was found in samples of blood obtained during normal spontaneous labor, but not during the other stages of gestation. So these prostaglandins act via 3 different ways, and uterine smooth muscle stimulants, as cervical primers, and as luteolytic agents, which means inhibiting the secretion of progesterone by corpus luteum. This effect has not been observed in humans. So the 3 different ways are they are uterine smooth muscle stimulants causing uterus to contract. The cervical primers, that means they are hastening the process of softening and dilatation of the cervix. And lastly, the luteolytic effect, which is not seen in case of human. The common adverse drug reactions of these prostaglandins are basically they are in the small doses they are okay, but there's some problems may occur at the larger doses: abdominal cramp, diarrhea, headache, fever, vasodilatation. So this cautiously must be used in presence of raised intraocular pressure, hypertension, diabetes, angina, and epilepsy. And they are contraindicated in the presence of cardiac, renal, and pulmonary or hepatic diseases. So different preparations are available from this group of prostaglandins: dinoprost, then the carboprost, which is having a longer duration of action; dinoprostone, which is given at the endocervical injection; misoprostol, which is also having another action, which is basically a prostaglandin analog used in case of peptic ulcer, especially drug-induced peptic ulcer as a prophylactic drug, but it is mostly used in case of as a uterine stimulant. So the main uses of the prostaglandins are therapeutic abortion, cervical priming, postpartum hemorrhages, then comes the induction and augmentation of term labor. As the obstetric regimens, the prostaglandins are complicated and manufacturer's literature should be consulted before using these type of drugs. These drugs can also be used judiciously in some different other indications, like misoprostol is used in peptic drug-induced peptic ulcer. So this is about a little bit about the oxytocin drugs, and these are primarily the oxytocins and prostaglandins. But beside this, there is one more drug which is very important in this regard, and those are called ergot alkaloids, the argometrin and methyl argometrin. It's obtained from Claviceps purpura. The chemistry of this ergot alkaloids is basically depending on the force, frequency, and duration of uterine contraction. It's going to be increased, and these drugs are basically they are having action on the uterus. Their mechanism of action is due to their partial agonistic action on also on serotonergic receptor as well as alpha adrenergic receptors. They causes contraction of uterine smooth muscle. That is the oxytocin action, but the magnitude of response depends on the alkaloid employed, the dose. The amino acid alkaloids basically shows a delayed but powerful response. Their dihydrogenated derivatives, however, are active only on pregnant uterus at term. Argometrin is basically an alkaloid, and the methyl argometrin elicit an immediate and powerful response. It has a dose dependent effect. Small doses produce an increase in the force of contraction with normal relaxation between the contraction. Larger doses, powerful, tetanic, and frequent contraction, and the resting muscle tone increases markedly. Very large doses cause a sustained contracture. Both amino acids and amine alkaloids are capable of stimulating the uterus during any phase of estrous cycle of gestation. As an oxytocin drug, this amine alkaloid argometrin has several advantages over the amino acid alkaloids such as argotamine. So argometrin is always preferred over argotamine. Why? Because the argometrin is effective orally. It elicits a prompt and marked contractile response even in small doses, less toxic. And thirdly, the devoid of significant adrenergic blocking and vasoconstrictor and emetic activity. So always argometrin is preferred over argotamine, but in argometrin is not given normally during induction of labor because it contracts the uterus totally. So both the lower part as well as the upper part, the fundus is going to be contracted, which is not happened in case of oxytocin. So oxytocin therefore is always preferred in case of induction of labor. Whereas in case of postpartum hemorrhage, we are preferring argometrin and methyl argometrin because they are basically given as a prophylaxis level, administered after the expulsion of the placenta, and the immediate action is observed with this. It leads to vasoconstriction and therefore stoppage of bleeding during these conditions. In abortion, where the loss of fetus is inevitable, argometrin may be employed to control bleeding. But don't prescribe argometrin to induce labor because the total contraction and sometimes severe contraction of uterus may lead to problem during the delivery of the fetus. So, in that case, for induction, oxytocin is preferred, whereas to prevent postpartum hemorrhage, argometrin is preferred. And if argometrin is contraindicated due to some reason, some cardiovascular problems or some other contraindications, then you can prescribe even oxytocin to prevent postpartum hemorrhage. The adverse drug reactions which we may encounter with argotamine and argotoxin are basically of various types, and it is actually happened due to direct vascular actions leading to thrombosis and gangrene. So, immediate withdrawal of the drug, use of antiemetics, administration of heparin, vasodilators like sodium nitroprusside for the treatment of peripheral vascular insufficiency are required to prevent, or rather to tackle that situation, or rather to manage that situation of argometrin toxicity. Argometrin and methyl argometrin may produce nausea and vomiting, but serious toxic effects are rare. They are used during phase 1 and 2 stages of labor, however result in death of fetus. As I mentioned before, the reasons were well explained before saying or starting anything on this topic. So, again I am repeating, in case of induction we will prefer oxytocin, in case of postpartum hemorrhage we will prefer argotamine, and even more than that argometrin. Argometrin is a better drug in comparison to argotamine. So, from uterine stimulants we will shift to the other group of drugs which are as a whole known as uterine relaxants, and the synonymous form of this is tocolytics. So, the tocolytics are the drugs which inhibit myometrial contraction. They are uterine relaxants. Not all uterine relaxants are effective tocolytics. Examples are like ephedrine, atropine, but they are used to prevent spontaneous preterm birth. Spontaneous preterm birth before the conclusion of 37th week of gestation may involve several contributing factors. Important among these are myometrial and fetal membrane overdistension, decidual hemorrhage, precocious fetal endocrine activation, and intrauterine inflammation and infection. The major goal in preventing preterm birth is to eliminate the risk of neonatal complication and death. Since the contraction or the contracting uterus is the most commonly recognized mechanism, stopping the contractions by using the tocolyte constitutes the major therapeutic approach. There are different drugs. Most important one of this is ritodrine, isoxaprine, salbutamol, the calcium channel blockers like nifedipine, the COX inhibitors like indomethacin, the one which is oxytocin antagonist known as atosiban, magnesium sulfate, then comes the ethyl alcohol, nitrates, progesterone are all tocolytic agents. Out of this calcium channel blocker, this nifedipine actually has no role to play mostly in clinical practice except hypertension in pregnancy. In that case, probably nifedipine sustained release preparations are given, but here also nifedipine can be administered sublingually or orally in the loading dose of 10 mg, and dose may be repeated every 20 minutes for 3 doses. And it is effective in reducing neonatal complications and relatively safer in comparison to other drugs. The COX inhibitors, like the one indomethacin, this one is basically a very toxic drug for gastrointestinal tract problems, or rather, it may produce peptic ulcer or gastric ulcer. But these drugs, given early, inhibit COX non-selectively and hence prostaglandin synthesis, and thus acts as a tocolytic agent. The beta 2 agonists are of different types. Salbutamol, which is mostly used in case of bronchial asthma, but here also the salbutamol sometimes used with alone, or sometimes it can be replaced by giving the drug like terbutaline. But the mostly used drug is ritodrine, and it's a selective beta 2 agonist on uterus and causes uterine relaxation. And it suppressed premature labor, it delayed delivery, and started at 50 microgram per minute IV infusion and increased gradually. Hypotension, tachycardia, arrhythmia, these are pulmonary edema are the common complications of this drug. So one must be careful while using ritodrine, and until the uterine contraction are controlled and then maintained for an hour thereafter, this lowest dose must be, as a maintenance dose, must be continued. The contraindications are if the mother is having diabetes or heart disease or receiving beta blockers and steroids. There are some drugs like nitric oxide donor, that is called NO donor. Nitroglycerin intravenously can delay preterm labor. Oxytocin receptor antagonist, which I mentioned before, that is the drug atosiban. It acts as a competitive antagonist of oxytocin, and it also can be very much useful because it is opposing the action of uterine stimulants, and the stimulant is naturally obtained from your posterior pituitary. However, it was associated with excessive fetal and infant mortality when used before 28 weeks of gestation. So it's not very much used in clinical practice. Magnesium sulfate is experimentally, this one is inhibiting the contraction of myometrial strips. Tocolytics may not always prevent preterm birth, thus there is no first line ideal tocolytic. However, these drugs offer certain benefits. A delay of 24 to 48 hours in labor can be utilized for administering a glucocorticoid so that the lungs is going to be matured, or it can decrease the occurrence of neonatal respiratory distress syndrome, or to transfer the patient to a center where neonatal intensive care unit is available. So ideally, tocolytic should not be given for more than 48 hours, and the treatment is going to be individualized. So in clinical practice, always you have to remember that action as well as the selection of a drug is varying from person to person. You have plenty of choices, you are spoiled for choices, but you have to select one drug, and you have to select the drug considering on the basis of the clinical features or the the conditions of a particular patient. So thank you so much for your kind hearing and kind attention, and this is probably going to be the end of my lecture for this session. Thank you so much.